Hello, and welcome to the session on building and maintaining researcher-participant relationships in a virtual world, the case of electronic consent. My name is Holly P.A. I'm a senior investigator at RTI International, and I'm happy to welcome you to this session. We're going to talk about the situations where we have re-envisioning of traditional researcher-participant relationships due to the growing adoption of electronic approaches that are designed to engage, educate, and promote informed research decision-making. One example is in electronic consent, and this is increasingly being utilized in large-scale research, especially in contexts where in-person consent is not feasible or practicable. But what does it mean to have a researcher-participant relationship that is different than the traditional in-person components, where those relationships are being replaced by virtual ones? That's the topic that we're going to explore today, and I'll introduce our panelists briefly. You're first going to hear from Nancy King. Nancy is a professor at Wake Forest School of Medicine, and she's the co-director of the Center for Bioethics, Health, and Society at Wake Forest University. She's going to lead us off with an overview of the ethical, legal, and social implications of electronic consent. She'll be followed by Meg Dorr, who is a principal scientist at Sage Bionetworks. She's going to present to us about her extensive experience using electronic consent and about Sage Bionetworks' approach to electronic consent and learnings from large studies, including the All of Us research study. I'm a senior investigator from RTI International, and I'm going to talk a little bit about the Early Check research study, which is a study that we're conducting in North Carolina on a large scale, and we use electronic consent to obtain parental permission for screening of newborns. The presenters will then engage in a brief discussion, and that'll be followed by the Q&A session. And while these sessions will not take the interactive approach that we initially envisioned for this symposium, we hope that it'll be informative and that we can have a nice discussion during the Q&A session. So with that, I'll introduce our first speaker, Nancy King.
Hello, everyone. My name is Nancy King, and I'm a bioethics scholar on the faculty of Wake Forest School of Medicine and Wake Forest University, and I work with the Early Check study that you'll hear about later. I'm going to be talking about the ethics of e-consent, but I'm not going to start from the beginning because the basics of autonomy, beneficence, non-maleficence, and justice are well known to this audience. What I'm going to talk about is an overview of some of the things to think about when doing a good job with e-consent, and you'll hear details to fill in my overview from Meg Dorr and Holly P.A. after I give you this introduction. So I'm going to start by talking about the revisions to the Common Rule 45 CFR 46 Part A, which actually governs research with human subjects, and that's funded by reviewed by OHRP. And there are some very important recent changes that really work very well to underscore why e-consent is a viable alternative. That is the reasonable person standard, which, trained as a lawyer, I know is misunderstood by a lot of people, but adding the reasonable person standard to the revised Common Rule is really a strong endorsement of the broad and creative capacities of models for e-consent when done well. And basically, the reasonable person standard says that the prospective subject must be provided with the information that a reasonable person would want to have in order to make an informed decision about whether to participate and an opportunity to discuss that information. It also says informed consent as a whole must present information in sufficient detail and must be organized and presented in a way that doesn't merely provide lists of isolated facts, but facilitates the prospective subject's understanding of the reasons why one might or might not want to participate. And that organizational structure can be very well served by e-consent, perhaps better than it can be served actually by paper consent forms in some cases. Now, this is the nutshell of why e-consent works. It can routinely offer information that is accessible and engaging, and therefore supports and promotes understanding for a lot of potential participants. And it can routinely include decision support components that encourage reflection on the reasons for making a choice, that reinforce key information, and that don't necessarily leave potential participants feeling overly quizzed. So that's the nutshell, but let's go through some more specifics. Promoting engagement and recruitment is an important component. Now, e-consent is, of course, desirable when in-person consent is not feasible, and that means it potentially increases access to traditionally underserved communities and groups. It makes the reach of a particular research project longer, and makes accessible groups that may not be able to be reached in person. It's also the case that this multimedia approach may be more interesting to potential subjects. And of course, we know that consent forms on paper are generally very dense and can be too long, and that is not encouraging to comprehension, and it may get people uninterested. And of course, we've learned during the pandemic that multimedia approaches to outreach are really essential when in-person connection isn't possible. And of course, e-consent is outstanding in terms of the possibility of multimedia approaches. Next, enhancing communication and decision-making. Using graphics and videos can add visual interest and make people pay more attention, and paying more attention helps to increase comprehension. It also accommodates a wide variety of different learning styles and can do so without the sometimes infantilizing language that makes low literacy learners feel condescended to. Graphics and videos are also very helpful for potential participants for whom English is not the first language. It's also the case that when you have to work on a small screen, a smartphone or a laptop screen, this helps to overcome the tendency to write consent forms at a far higher than optimal reading level, because you just can't put that much text on a screen and hold people's attention and get them to read it. And of course, multimedia approaches to teaching are becoming more essential during the pandemic, and they're also becoming ubiquitous. So we're getting more used to actually doing the things that that a good e-consent platform recommends. Next, relationships and trust building. Well, this is really important because how one creates trust in an in-person consent process is dominated by the fact that the consent form usually needs to be translated and amplified by somebody sitting with you going over the form. And that may actually be the only time that a relationship is built in some studies. So many studies really only have a time-limited relationship and time-limited trust building to begin with. Now, e-consent builds trust in a different way, through having a clear and accessible platform, and also because the platform combines the substance of consent and the process of decision making, so that as you go through an e-consent model, you are actually learning and understanding so that the decision is not separated from the learning process. And that's a very different trust building model. Now, what e-consent really needs to do, however, is to build trust and cement whatever degree of relationship there can be by making extensive follow-up available, which is more than just presenting a platform. It means that the study team needs to devise ways of being accessible in real time, by phone, by receiving texts and responding to them, by online chat functions, anything that can make it possible for potential subjects to ask questions, to follow up, to get more information, to build a relationship if that's something that they need, and to just basically demonstrate that this is about the relationship and about engaging participants as partners in important data gathering, not just something to get signed and forget. There are, of course, challenges and caveats when using an e-consent platform, and some of those will be discussed in a brief chat that we'll have with you and in the Q&A later. But making sure that you have identified the correct participant is a different sort of a challenge in e-consent than when you have somebody in front of you and you can verify their identity on the spot. Privacy and confidentiality are also issues that need to be protected differently in a digital environment. Retention and recall is different because if you're handed a copy of the consent form, then you may have it available if you need to remember what it is you agreed to. Retention and recall in an e-consent model means going back online and looking at what it is that you agreed to, so there have to be ways of doing that. And of course, the biggest challenge, which is something that we are all working on and everybody has a strong interest in doing something about it, is reducing the digital divide. Because we know, even if a study is trying to reach underserved populations, they may be underserved in more ways than one and may not have access to reliable internet service, enough minutes on their cell phones. So this is something that really, really has to be dealt with, and this goes sort of beyond the general confines of e-consent to a much larger question that we know that we all need to confront. So just to conclude, e-consent models, when they're done well, have the capacity to promote informed decision-making about research participation in ways that are not always possible when a traditional paper consent form model is being used. There are a lot of avenues for recruitment, retention, and trust building and engaging of participants, which have to do with the creativity that can be used in e-consent and that inherent combination of the form and the substance of the consent process and platform. If an e-consent is done thoughtfully and comprehensively, it can really improve understanding and engagement of participants, but it is really essential to make that comprehensive consideration and to really think about it. This isn't just a one-off kind of, well, we've got the study and so let's just put consent in there. It's really essential to think differently when you're using e-consent, and this is a reminder of the importance of the consent process to the entire process of research. So with those comments, I'm going to thank you and turn it over to some more detail and some more examples, and look forward to talking with our audience later on.
Hello, everyone. My name is Meg Dorr, and I will be speaking to you today about design and development work that I've done with my colleagues on e-consent. Before I get started, a few disclosures. I do get royalties and return on equity for an invention that I helped with while I was at the Cleveland Clinic. I received salary support from the National Institutes of Health on a number of grants, including through the All of Us Research Program. I volunteer for a number of organizations, including the Global Alliance for Genomics and Health and the National Society of Genetic Counselors, and I'm a founding member of the Digital Medicine Society. And most importantly, I've not done this work alone. My presentation is informed by a number of sources, including several papers that I've co-authored, but the views that I'm presenting are my own. So first, a little bit of background about SAGE Bionetworks. So SAGE is a nonprofit open science organization, meaning we try to share all of our knowledge as quickly as possible with as many people as possible. We're not related to Sage Publishing or to Sage Pharmaceuticals or to the fly fishing company, although many of my colleagues really do like to fly fish. So 5 years ago, in March of 2015, which seems like, several lifetimes ago now, Apple launched ResearchKit, which was a platform specifically for app-mediated research studies. And we partnered with them to develop the back end, the technical end of the studies platform, and also with them to develop an informed consent process to bake in to this software platform. So how do you go from an in-person process that looks like this to a process that works on phones like this? When it comes to consent, there was a lot of work to be done. Anytime you're doing something new, especially when it's new and shiny, it's always important to remember that what's been done has been done again. So we had a lot of work to do, but we had a lot of evidence from previous work in informed consent to build upon. All of the knowledge that we've gained about informed consent, we have put together in our Elements of Informed Consent, which is a free resource that's available by the web. You can Google or use this link. It has examples of what we've done. It has checklists and other resources linked out from it. And so there's a compendium of all of the things that I'm going to be talking to you about, and many things that I won't get to today. So I encourage you to go and take a look at Sage's Elements of Informed Consent. We update it regularly as our knowledge base grows. So when we were originally designing the electronic informed consent, what were the design requirements? It needed to be delivered by app or by web browser. It needed to be participant self-guided and self-paced. And it might have been entirely remote with 0 in-person steps required. But there's some challenges, right? People don't really read on their phones. Most of us just sort of scroll. 1 in 5 people in the United States reads at or below the 5th grade reading level. So how would we make any written interface understandable to the full audience of people in the US? And most people who join research studies can't answer key questions about the studies that they've joined. So was there a way that we could ensure that we got our important points across to the people who were viewing, the prospective participants who were viewing the electronic informed consent? This was the first design that we came up with. You can see that there's a navigation bar at the top. We're pretty used to that in our online lives. Then there's a visual information area. There has been some really interesting research done that shows that when images relate to text, our reading speed slows down. And when our reading speed slows down, we're more likely to pick up information that's important to us. So creating a visual information area with an on-topic image was really important, we thought, to this electronic informed consent framework. We then used a headline, subheadline format, which will remind you of all of the information you see on the internet, because that's how we quickly can pick up information. And we tried to simplify the language we were using. We also have a link there for learning more. So in our original design, you could click on the Learn More and navigate to another screen with additional information. This is consistent with best practice in adult learning, which shows that adult learners are much more likely to retain information when they ask for the information or when they demonstrate their need for the information. And then finally, an instruction area at the bottom. This will show you it in motion. So you can see we're moving through this very quickly, but you can see how the images draw your attention to the topic and flow from one screen to the next. So this is the consent for one of our first Apple Research Kit studies, Journey Pro, which is a breast cancer study. And then finally, we get to sharing options. So within our e-consents that we at SAGE do, we often give participants the option to share their data not only with us, but also with qualified researchers worldwide. Interestingly, about 70% of participants opt in to more broad data sharing. So let's talk for a second about in-person steps, 0 in-person steps. For people with low health literacy, this can be really a challenge because whether we realize it or not, when people with very low literacy are consenting in person, they have an interpreter there with them, the study coordinator, right, who quickly adapts language and says things in different ways to help people understand. So what sorts of language, context, visual cues, and multimodality support did we need to bake in if we weren't going to have that interpreter right at the side of the participant? For people with cognitive impairment or decline, they're consenting without oversight, without a study coordinator to sit there and ensure that they're understanding what they're getting themselves into. This led us down the path of thinking about adding assessments to our electronic consent process. And then finally, the enrollment of children is a really tricky one. If there are no in-person steps, you can see here's an example screen from a study that was done a couple of years ago, where the parent consented and then handed their phone to a child to assent. But let's dig into the low literacy and the quizzing or assessments. So just as a reminder, health literacy in the United States varies dramatically across the entire United States. Forgive me for only showing the contiguous 48 states. This map shows health literacy by quartiles. Green is the top 25%, yellow, the middle, top middle, orange, the lower middle, and then red, the lowest 25% of, or lowest quartile of health literacy. So if you're trying to enroll people and you're trying to enroll a representative sample, even within a single state, you really need to be taking health literacy into account. For the All of Us research program, this translated into, instead of having a learn more screen, having embedded videos. So again, you can see it's the same sort of structure as we developed for the Apple Research Kit, with a main concept and then a subheadline. But instead of having a link out to a learn more, we have a video with closed captioning. And so this video plays for the participant, and they can't advance to the next screen without having viewed the video. The videos in the All of Us research program's informed consent range from about 10 seconds to about 60 seconds in length, and there are 9 of them spread throughout the electronic informed consent process. Now for a little bit about the quizzes. So as I was saying, when you have somebody with cognitive impairment or potential cognitive impairment, and you're not seeing them in person, how do you ensure that they are knowingly consenting for participation in research? So we created 2 forms of quiz, a formative evaluation and a summative evaluation. A formative evaluation is really a form of teach back. It highlights and reinforces key concepts. It creates a moment of pause within the electronic informed consent process, and it encourages participants to seek additional information. But it is not a hard stop. Patients or participants can get all of the answers incorrect and still join the study. It's really more of a reflective process. The All of Us research program uses a formative evaluation as part of its informed consent. So people complete the electronic informed consent, they navigate through it, and then they answer some questions and can go back and review information if they haven't understood. By contrast, a summative evaluation is a hard stop. It's there to measure mastery, and it acts as a gate to participation. So if you're enrolling a vulnerable population and you want to make sure that they understand key aspects of the study, for example, the voluntary nature of the study, you could use a summative evaluation as a gatekeeping activity prior to the participant joining the study. So to prevent people from joining unless they can get the correct answer. Speaking of the All of Us informed consent process, the formative evaluation data from our electronic informed consent are really pretty strong. We have a manuscript that will be coming out shortly in the AJOB Empirical showing that regardless of educational attainment and regardless actually of annual household income, more than 90% of participants were able to correctly answer key questions about the study, with one exception: questions about privacy. So questions about privacy, although we used exactly the same teaching techniques with videos, with voiceover, with formative evaluation questions, with reinforcing information, people struggled to answer correctly questions about privacy. And it turns out people are just phenomenally bad at understanding privacy. Terms of service and privacy policies govern our online privacy, and most people never read them. In this study, as one example, they added in a clause into the terms of service for a fictitious social networking site that said that you had to give up your firstborn child in order to use the services. 98% of people agreed to these terms. Now, I mean, admittedly, during COVID, many of you might be willing to give away not only your firstborn child, but all of your children. I know online homeschooling has not been great for a lot of people. But it just goes to show most of us are not reading terms of service or privacy policies. And they're really, really important. So privacy policies cover the collection and use of your private information. Terms of service cover all of the rules around a website. And both of these, if you're using an electronic informed consent, are important and salient to your electronic informed consent. If you're using a website or you're using an app to deliver your electronic informed consent, you need to make sure that you compare your informed consent and the terms that you state in that to what's said in the terms of service or privacy policy to make sure that they match one another. Oftentimes, electronic informed consents don't even link to privacy policies or terms of service, and I would actually strongly encourage people to change that practice and to include them as part of the electronic informed consent process. SAGE has done some work with privacy as well, so we have a privacy toolkit, just like we have an electronic informed consent toolkit. It has design patterns in it, best practice design patterns in it. You can contribute to the resource. You can look at the designs other people have contributed. Again, it's free and open for use. I'm going to share one of those design patterns with you now around privacy. So let's imagine that you were joining a study and it was an app-mediated study, and the participant is in there and they're deciding what permissions to give the app during the onboarding process or during the informed consent process. And they say like no to everything. Like, why do you need access to my camera? Why do you need access to my motion sensors? And then they get into the study itself and they need to do one of the activities, and the activity requires one of those sensors. They then have to navigate back to the system settings and then open the settings, change the correct setting, and navigate all the way back. And we found that this is really, really burdensome for participants, and they tend not to complete these steps. They just leave. But instead, you could ask for just-in-time permission. So rather than asking for permission to all of the sensors at the beginning of your study, you could, as they arrive at each task, say, we would like access to this sensor because, and then they could turn it on or off, and then if they turn it on, then they could do the activity. So these types of design patterns may be helpful to participants in understanding the privacy of the data that they're giving and what types of data they're giving. So just as a reminder, we have 2 free resources. We have the Elements of Informed Consent, and we have SAGE's Privacy Toolkit. Both of them, I think, would be valuable for those designing electronic informed consent processes. We're going to talk more about them in our discussion, and I would encourage you to go take a look. Thanks so much.
All right, well, in the next session, we're going to talk about early check. And so I'm pleased to present to you a bit about the early check research study, which is a study we're conducting in North Carolina of screening newborns. We're going to discuss some of the challenges and opportunities for relationship building and use of electronic consent. I have a few disclosures before we get started. First is that we have several companies, both in the device side and on the therapy side, who support early check. One is Assuragen, and they support the Fragile X screening. And then we have Sarepta Therapeutics and PerkinElmer, and they both provide partial support for our screening of CKMM for Duchenne and related muscular dystrophies. So what is early check? Early check is a research study, and it's designed to develop and evaluate methods that allow us to offer voluntary screening to newborns, and that's in the state of North Carolina currently, where we have about 120,000 infants born a year, and those infants are all potentially participants of early check, and so parents of those individuals are recruited, and we attempt to consent them for the early check research study. The other aim of early check is to obtain data that can inform policy around newborn screening. So I'm going to quickly run you through the process of early check, just so that we can set a basis for talking more specifically about the electronic permissions approach and some of the relationship issues. So there are 2 options for enrollment. So parents are the ones who enroll their infants. Infants are their participants, but the mother specifically is the one who can give permission for her child to participate. And the mothers can enroll at 2 time points. One is prenatally and one is postnatally. We have a variety of different recruitment approaches that depend a bit based on whether it's prenatal or postnatal. But in any case, parents then are moved into the electronic permission portal. The early check research portal provides all of the information needed to make an informed choice, and I'll talk a bit about our evaluation of that statement in a few moments. But a mother who's interested goes to the research portal, goes through the informed consent process, and can decide whether to enroll her child at that point. If the mother enrolls her child, we conduct the screening using residual dried blood spots from the state laboratory in North Carolina, and that testing is actually done at RTI. And if the child screens negative, which is what happens for the vast majority of participants in early check, the parents actually receive the result, the normal result, through the research portal as well. And if the child screens positive, that's a discussion for another presentation, but that child receives a confirmatory test, genetic counseling, clinical evaluation, and then support to integrate into the clinical network, which for the conditions we screen for means soft handover into a specialty clinic. There are many challenges in electronic consent, and you've heard many of them from the past 2 presentations, but I'm going to highlight a few. One of them is supporting informed choice while not acting as a barrier to recruitment. So for large-scale research to work, you of course need a lot of participants, especially for rare disease research like we're conducting in early check, and so we want to make sure that we really inform people properly and mothers can make a good choice, but also that we're not acting as a barrier. We need to meet the needs of a diverse population. North Carolina is quite a diverse state. We need to make sure that we're implementing sufficient and feasible communication approaches for individuals to contact the Early Check research team, and of course, meet regulatory and ethical requirements. But a sub-aim in all of this is to develop an approach that's not only acceptable to participants, but one that builds a sense of relationship and is perceived as worthy of trust. So with that, I'm going to show you some of the components of the Early Check Research Portal and talk just very briefly about some of the things that we try to do to engender that sense of relationship and trust. So what you're seeing on the screen now is the welcome screen, the first screen that individuals come to when they come to the Early Check Research Portal. And through a lot of user testing and engagement with our end users, we have done a portal that we intended to be warm and friendly. We use a lot of photos, we use a lot of different graphical elements. And specifically, one of the ways I'm going to show you in several of these screens is that we offer people different ways of engaging with our content so that it's comfortable for different people from different kinds of backgrounds. So here, this shows an example of a video. So our introductory video provides really the lay summary of the study, but we also provide different written materials and infographics, and there is an option for individuals to hear the whole thing read to them. This is another screen that shows the simple language we use, what do babies have to do, what do parents have to do, and kind of walk them through the steps to sign up and the steps to participate in a series of screens. We also make the process to actually enroll, so we make the consent process very clear to parents through this portal. You see here an infographic that walks them through the steps that they're going to take actually in the consent, and by showing people exactly what to expect, we build trust and then actually do what we said we were going to do so that we continue to build trust through the process. So things are very, parents can anticipate and know what they're getting into. Here's another example of use of different kinds of graphics. And this is again intended to build a sense of relationship and connection as well as to inform. So here we have an example where we have a video. Under the video, there's written content for people who don't prefer to learn by video. And we also have an infographic that goes through really the exact same procedure. And this is the screen and set of materials that engage them around the processes of Early Check. We also, as is traditional in many kinds of media, we don't use a talking head. We decided not to do that after looking at a lot of literature and engaging with our end users, but we do show photographs and introduce the experts. So there are many places where individuals who are thinking about participating in Early Check can see and sort of meet the experts who are involved in this process. We also include components around decision support. And so this is something that is a bit hard to replicate the in-person interaction, but we're building in some decision support components so that we can show individuals rather than discuss with them why some people may and may not want to participate in Early Checks. We're very transparent in here about why this is maybe a good choice for some parents and not the right choice for other parents. We do that through text, through video, as well as through a checklist, very brief interactivity that individuals can engage on the portal. This is an example of a quiz. So our quizzes are not traditional quizzes. We do a check-in and we put the sort of focus back on ourselves, where we say it is our job to explain Early Check to you and let's see how we're doing. We provide a question with a core element around Early Check participation, and then we actually answer it immediately. This was after, again, a lot of engagement and user testing about building a sense of relationship rather than doing something like a quiz where sometimes individuals feel then that they're being threatened or challenged. And as you've already heard, many opportunities to contact us. And so we give people opportunities throughout the process to communicate with the research team. so that we can make sure that we're being engaging and responsive to the needs of our population. I will say that very few people actually contact us in this way, but when they do, there's a variety of different mechanisms, and we have trained staff who are very well informed about how to triage questions to appropriate individuals on the team. So with that, I've talked to you a bit about what we intend to do, and I'm gonna quickly talk a little bit about how we're doing. So we're doing a number of different evaluation components, and I wanna show you some preliminary analysis. In terms of spread, we've screened over 10,000 infants at this point. We have good reach in North Carolina, where we have infants from every birthing hospital in 99% of the counties in North Carolina. We have now implemented an evaluation survey, and so I'm going to show you a sample of just over 200. This is based on about 3 months of data, so this is a preliminary analysis and a data set that's going to grow much larger. We asked them a series of questions. I'm just going to show a few here. The first is about whether the information in Early Check made it easier or harder to make a decision about whether to sign up, and the green is easier and the yellow is somewhat easier. So you can see that the large majority of our participants are indicating that it was easy to sign up because of the information. We asked whether they got enough information to sign up for Early Check, and again, the vast majority said yes, that they had. We asked them an important question about trust, whether they trust the information, and the large majority either strongly agree with that statement. This is the last survey screen I'm going to show you about decision regret. We use a decision regret measure as one of our outcome measures. And so you see 4 statements in that measure. The first statement and the third statement are actually reverse scored for you on this screen. So the first is the choice has done a lot of harm. We reverse scored that. I would go for the same choice if I could do it over again. I regret the choice that was made. We've reverse scored that, and it was the right decision. So you can see from the green, these are individuals who strongly agree with these statements. And so you can see that, again, we're finding very low decision regret. So the final thing I'm going to show you is just a quick snapshot of our Google Analytics. And this is from October 15th, 2018, when we initiated Early Check, until quite recently, September 16th. And I'm going to show you just one quick analytic. One of the interesting things that maybe we can talk about in the Q&A session if folks are interested is how do we measure success in electronic consent? The outcomes are varied, and there's a lot of interesting debate about that. But one of the things that we track is our conversion rate. And so that's of people who get to the portal, the research portal, how many of them actually give consent. And so in Early Check, when people hit the homepage, which you saw with the introductory video, about 28% of those people actually end up converting to give consent. People who come to the second page, which is the process overview, 59% of those people ultimately give consent. If people go through our eligibility screener, which is the third screen, which I didn't show you today, 70% of them give consent. And if they get to the fourth screen, then almost 80% of them give consent. So you can see that our conversion rate and how we can look at different ways of indication from the actual analytics of the electronic consent platform, which is a really robust tool to use to look at the outcomes of informed consent using these platforms. So Early Check is a study that requires lots of partners. We have excellent partners in Duke University, UNC Chapel Hill, Wake Forest, and here you see Nancy King, and our North Carolina Laboratory of Public Health, as well as many talented individuals within our center at RTI and our unit. And then I've already mentioned some of our funders and sponsors. We also have funding from the NIH and from 2 nonprofits, the John Merck Fund, three nonprofits, the Muscular Dystrophy Association and Cure SMA. So with that, I'm going to close, and we're going to move on to some discussion. All right, we're going to now move to a discussion with the panelists, and we have some questions that we're going to pose and discuss amongst ourselves, and then we'll open it up for the Q&A period. So we thought we would start by talking a bit about some of the specific lessons learned and the tensions that we've experienced regarding the process of adapting traditional informed consent to a more user-centered electronic format. So who wants to kick this off?
I would be happy to start. So I really liked this question because I have a lot of lessons that we've learned over the many years we've been working on electronic informed consent. But one in particular that I wanted to share is from my work on the All of Us research program's informed consent. So we had a 48-person working group who worked for more than 9 months to develop this informed consent process. To say that we thought about every word would be a vast understatement of the amount of attention that this group paid to all of the aspects of the electronic informed consent process. So we put this piece of work together, of which I am tremendously proud. And then we've done some follow-up studies on it. And one of the studies that we did was qualitative interviews with individuals who have reading level of the 4th grade or below. So people who are completely illiterate up to a 4th grade reading level. And we did some testing of the different word pairs that we use, different ways of phrasing things. And one of the immediate pieces of feedback that came out of that work was that to people of low literacy, the words drugs and medicine are not synonymous. Now, that insight has nothing to do with it being an electronic platform for this consent. It's really a fundamental insight about consent generally in the ways that we describe medical research. To a lot of people, drugs are bad and medicines are good. Medicines are given to you by your doctor, drugs are illegal. And so I think the lesson that I came away from that with is, even on this beautiful, shiny new platform where we have so many options for learning and teaching in different ways to make the informed consent a more interactive process, a process that's more inclusive, we can't forget the fundamentals that we've learned along the way about consent generally. Language and word choice are still so important, even when we have all of these multimodality ways of teaching.
Well, and I think to follow up on that is it's really important to remember that not only do we have to remember everything that we've learned from from working with paper consent forms, but we also have to remember that investigators and study teams and IRBs are still more accustomed to working with paper consent forms. And as an IRB member in the past, I've very often seen the situation where somebody just takes chunks out of the protocol and plunks them into the consent form, and nobody does very much more with it. So both investigators and study teams actually need support and time and encouragement to make transitions to a new platform, because they need to think differently and really sort of start fresh. But in addition, IRBs also, some have become really familiar with e-consent, but others also need reinforcement and support to look at this very new platform with fresh eyes.
Yeah, I agree with all of these comments. And I think one thing I would expand upon a bit about process, there may be a couple things I could build on. One of them is thinking about using existing resources and experts. And in developing a different kind of a process and a different kind of approach, it's important that we expand our consideration of, number one, the time and effort it takes to develop these materials, because it is a different process. And it should be a different process than developing a more traditional informed consent. But the other component I think both of the other speakers brought up is the idea of experts and consulting with experts. And it's important when you're thinking about this new kind of media and a new way of presenting information to expand who you think are the experts. And so, for example, we did a lot of user testing, and Meg touched on that. And that's extremely important to develop a product that's actually user-friendly and can support people in making their own decision without that engagement that we usually see in informed consent. But another component is thinking about experts a bit differently to include people who have been through an IRB process with electronic consent. That's an extremely important piece of feedback. We consulted with external advisors from external IRBs to make sure that we were being very careful about meeting all of the required criteria in this new format. So I think starting to be a bit more holistic in thinking about who the experts are, and to include people who have expertise in multimedia and bringing those folks in so that we're making the best of a set of expertise that needs to be a bit different than in traditional informed consent.
Yeah, Holly, off of that point, there's a team at Yale who've been doing some really interesting work with using avatars in electronic informed consent for assent with children. And they brought in a children's book author to help them create the storyline for their electronic informed consent. And I really thought that was a brilliant move, because it brought in somebody who is really adept at writing and getting essential messages out to kids in language that they're able to understand and readily connect with. And so expanding our pool of experts is tremendous advice.
Yeah.
Now, oh, I'm sorry. I just had a point off of what Nancy was saying that I wanted to share. So, one of the points that that Nancy was making was around taking the time, and actually one of the points that you were also making, Holly, was around taking the time to really process and make sure that we have this electronic informed consent process time to develop it. And so I was going to say, at Sage Bionetworks, we're a nonprofit open science organization, and we've put all of our knowledge about electronic informed consent out into the public domain. But honestly, if I had a penny for every time Sage has been approached to make a template for electronic informed consent, we would have more money than we get from the National Institutes of Health. I mean, many people, I think, well-meaning people, would like this to be much more turnkey than it is. And I think we need to remember that informed consent should never be a turnkey process. It should never be a copy, cut, paste process, that we need to take the time to be deliberate in what information gets expressed in the electronic informed consent process.
Can I add one thing to that? Because that's such an interesting observation, because I'm thinking that investigators never view putting the protocol together as a turnkey process. We're used to thinking about research as, well, yeah, it fits certain parameters, but you really have to start fresh depending on what you're doing. Mm-hmm. And especially with e-consent, which has this really interesting combination of the form and the process as part of the platform, it's a really good reminder that informed consent is really a fundamental basis for engaging with human research participants. And so the idea that it's just something that you have to get past in order to get to what you really want is kind of not the right way to think. And yet we've sort of fallen into that. So e-consent gives us an opportunity to think really differently about the process of human subjects research. And I think that's a really good thing.
Yeah. Yeah, I agree. I mean, I think it's one of the incredible benefits, and there are, I mean, I think we showed you in the panel, there are a lot of really incredible benefits and opportunities that are bidirectional. They can support the research team, but for goodness sake, should support our potential participants and our participants.
Mm.
But on the other hand, to be, you know, to be completely transparent, there are challenges too. And we raised some of those challenges, but I think, you know, one of them I'll bring up maybe for a little group consideration is the idea of identity verification. And I bring this on up when, right, you know, right after Nancy's comment about needing to think about, I guess, sort of fit for purpose, because identity verification in the electronic world might look really different depending on the level of risk that your study entails, who your research population is, how you're engaging with them. So, you know, for example, in the early check study, we actually don't have a formal identity verification step. We don't look at anyone's IDs, which some studies do. They have, you know, someone send in a copy of a identification document, or send them a FedEx and have them receive it. There are all sorts of very creative ways people have done to do identity verification. And for our study, we don't have that. We actually are asking for pieces of information that we're matching up to information we already have from a state database. There are risks and downsides to that. We've uncovered situations where the mother later on informed us that actually the father was the one who signed up the baby and the mother was not informed, and we had to go back and do some work with our IRB and work with the families. So there are challenges that come as well that we don't see, at least not very frequently, in traditional informed consent.
Yeah, for sure. So, you know, for the All of Us research program, and for most of the research kit studies that SAGE has been involved with, we're not collecting data that's so sensitive. You know, we're collecting data from a wearable device or from a mobile app, or from, you know, patient completed surveys. And then for the All of Us research program, there's an in-person visit, and the identity is verified there before a blood sample is taken for genomic analysis. And so I think that one of the things that was a revelation for some with the electronic informed consent was that you don't have to necessarily do identity verification up front. You know, you can, depending on the nature of the data that you're collecting, you can wait until you're going to have an in-person visit for a sample collection, or some other natural intersection point for an in-person visit, and then do your identity verification there. It does, though, raise a lot of questions for more vulnerable populations like children, like adults with intellectual compromise. You can start to get into some tricky waters there.
Can I just add one thing to this discussion, which is, and this is not something that's likely to be as much of an issue for IRBs as identity verification and some of the privacy and confidentiality considerations are, but it's something that is at least quite different from paper consent, which is recall of the content of what you've agreed to is different when you have an in-person encounter and are handed a copy of the consent form. You may be able to say, oh yeah, I have that and I can look at it at any time. Now, for a population that's relatively young, like the population of mothers giving permission for their children to participate in early check, everybody's used to going online to find that information, but it still counts as an extra step. So it's just different to think about what it means to remember what you've agreed to and how you get to that memory if it should come up. And the one thing that I think also needs to be mentioned here is that depending on the population that you're studying, they may be very familiar with online platforms or not. But there also is the digital divide to consider. And I think that one of the things that we haven't gotten good enough about yet, and it's not something that e-consent can really deal with, it's a larger societal issue, that that having access to digital platforms is much easier for some people than others. And I think that's something that e-consent can only benefit from when we figure out how to make this really important aspect of life available to everybody.
Yeah, we're running into that with the co-VPN network, the COVID vaccine trial network. When we think about using e-consent in developing nations, you know, you've got bandwidth issues, access issues that are really, really significant. So within the United States, the digital divide, I think, is very important. But as soon as you start to do a multinational study, it can become a really essential design feature or design consideration as you consider how you're going to make your e-consent.
Yeah, I agree. And I'll just add on a more positive component of this is that, of course, the e-consent platform also does, though, allow people who traditionally have not had the kind of representation that we would hope in research to have alternative ways to engage with the research platform. And there is, you know, some suggestion that people who might not actually engage in a face-to-face encounter in a clinical setting will engage in these kinds of platforms. And so I think it's a really interesting area for ongoing research around how we can balance these needs that potential participants have and ideally make these platforms available to everyone.
Yeah. Yeah, I think to Nancy's point, you know, that there's this larger societal issue, but as we achieve more digital parity, Holly, to your point, the inclusivity of studies just increases exponentially, especially when you think about rural populations or working populations who are working at times when they can't, for love or money, be able to get in to a clinic, you know, at 10 o'clock on a Tuesday.
Exactly. Well, I'm going to give Nancy a last word, and then we're going to actually turn it over to some Q&A. So any final thoughts, Nancy?
Oh, I think it would be helpful to spend a couple of minutes talking about trust and relationship building and how that's different in an e-consent platform. I think what's really interesting is, again, the combination of the form and the process, which enables relationship building almost inherently, because as you're going through an e-consent platform, you're learning, you're engaging with multimedia and so forth. And so it just does more than just being handed a very dense paper consent form. But at the same time, one of the things that's going to be important, especially as we are able to expand who can be involved in research, is finding ways to make sure that they know that the investigators are there and available and interested in answering questions and helping them, so that every e-consent platform really needs to be accompanied by different kinds of often real-time access, so that people can get in touch with the study team, can ask questions, and that can be done in any number of ways, including, you know, online chat and other kinds of things that people are familiar with. But it's absolutely essential to say, well, it's not just the e-consent platform alone that helps us in all these ways, but you really need to be engaged in addition in order to build trust and relationships, even if they're relatively brief. So there's more that investigators need to do, and there's more that IRBs need to look for in addition to e-consent.
Great. All right, thank you. We're now going to open it up to group comments. Please send comments. Welcome to this session on building and maintaining researcher participant relationships in a virtual world, the case of electronic consent. We look forward to having some questions and answers session with people who have joined. Can everyone hear me, first of all? Okay, I'm seeing some nodding. That's very good. So what we'd hoped is that we would be able to ask everyone to keep yourself on mute when you're not asking questions, but to allow there to be some dialogue in this session. So please do feel free to unmute yourself and ask questions and have some discussion. But during the time when the panelists are discussing or other folks are asking questions, please do try to keep yourself muted so that we don't have a lot of background noise. So I'm going to go ahead and open the floor. We do have a couple of things that that we thought it might be fun to chat about, but we do want to make sure that we focus on your questions and answers now. So does anyone have a question to start? I'm going to try to look at the chat as well. Who wants to kick us off? All right, well, since people are still joining, I know it's hard to start a session when this is, it's not like it's not the same as in person, which is perfect given our topic. Making relationships a little more challenging in this sort of situation than it is in having a traditional engagement at a meeting. And again, this is exactly what our session is about. So I'm going to actually go ahead and ask the panelists to react to a question that I've gotten a lot lately, and some of you may have in your minds as well, which is thinking about the way our world has changed and the difference in how we engage in our relationships with folks, regardless of the setting, and specifically to have maybe Meg start off by talking about the experience of how COVID and the changes that have come in our culture for the past 9 months or whatever the count is now, has impacted, if at all, the approach to electronic consent and engagement that you've been working with.
Well, thanks for that question, Holly. So COVID, I think, has just provided a little bit more fuel for the fire for electronic informed consent. We've seen a lot of people reaching out to us for advice and guidance on how to implement electronic informed consent, just because everyone's needing to try to make as much virtual as they possibly can. We're working right now, actually, to study remote an electronic informed consent process for Alzheimer's study. So looking at people with cognitive decline and seeing whether we can use electronic informed consent effectively in that particular patient population. But keeping the most vulnerable people out of the places with the highest concentrations of COVID is really in everybody's interest. And so it'll be interesting to walk that study forward.
Yeah, maybe I'll tell our experience in the early check study, and then maybe Nancy could respond with some of the thinking through ways this might facilitate or exacerbate some of the ethical challenges with electronic approaches. In the early check study that we've been working on with electronic consent, we've actually found our participation rates have gone up somewhat, which is really reassuring, and it's very different than many researchers have experienced. And so in that way, we've been very pleased with the response. The other thing that we're finding, which is interesting, it's showing a beginning of a culture shift perhaps, is that we did and continue to some extent to have people who contact us and say, I need an alternative way of providing consent because I can't access this platform. And we've actually found that people have this dramatic technical leap, and it's certainly not everyone. I know there are people systematically studying this, but the sort of tolerability and acceptance of using these platforms on a day-to-day level has really increased. We found just anecdotally capacity of folks who before were calling with challenges and needing more assistance, who those calls have largely stopped. And we do think it's just because of more engagement in technology and different kinds of platforms, which has been an interesting phenomenon. Nancy, do you have thoughts about the ethical implications?
Yeah, I think that there are actually they fall into, I guess, two principal buckets. One is something that you just mentioned, which is the possibility that the digital divide still is affecting potential participants. And I think that the kind of work that Early Check has been doing to try to reach everybody in the state really kind of highlights that, because across North Carolina, there are places where internet access is rather poor. And people can always use cell phone minutes, but they may have other priorities for those minutes. So I think that one of the things that COVID has shown is that we really do need to address the digital divide for everybody. Having said that, when people do get access, it is a really great way to engage with people. I see that some people in the chat are saying, well, this really is easier. And yeah, I agree. I think there's one additional thing to consider, though, which is the balance between synchronous and asynchronous engagement with potential participants and participants in research. And I was just before we got started, we were chatting about teaching, and I think actually that teaching online works very well when you have at least some synchronous component where you're directly engaging with students. But I'm not looking forward to getting ready to teach a completely asynchronous class in the spring semester because I lack that direct engagement. And I think when you're trying to build relationships with participants, some of the means of building in a synchronous component, even when enrollment is through a platform that's entirely e-consent based, is probably going to be important.
Yeah, that's helpful. I'm wanting everyone to note that there is a chat going on. So if you don't have the chat window open, you might want to open your chat window, where Aubrey has a comment about patient partners and participants thanking them for the electronic engagement and reporting how much simpler it is. As you saw during the presentation, we've also had very positive feedback. And of course, we have to be careful with bias there, because the feedback from people who participated that might be quite different than people who have not participated, which is a challenge for our study and many studies, is getting those people who don't engage and don't end up enrolling to give feedback about processes. But I agree, there's a lot of very positive feedback we've gotten. I do want to note there's one question here, and maybe I'll go ahead and read that and ask Nancy and Meg to respond to that, which is legal barriers. So the legal barriers about informed consent, there are regulations that certainly cover consenting generally, and then electronic consent more specifically. So Nancy or Meg, do either one of you want to speak to that?
Well, I can say a little bit, and I'm sure Meg has even more to say. I'm not sure that barriers is even actually the right term. There are regulatory requirements that have to be fulfilled. And one of the considerations that looms probably largest is making sure that you are actually engaging with the right person. Because when you are doing in-person consent, getting consent in person, you know who's in front of you, sitting across the table, and that's a little bit harder to ensure when you're doing e-consent. But there are plenty of methods for doing it, and I actually think that the changes to the common rule are actually tilt in favor of using models like e-consent for a whole variety of reasons, including making information more accessible and better organized for potential participants. So I think there are some regulatory considerations. I wouldn't say that I would call those legal barriers.
Yeah, I would agree, Nancy. Certainly, all of the guidance that I've seen out of OHARP on this issue is really pretty clear that they're enthusiastic about researchers using electronic platforms for delivering multimodal consent experiences. Again, because of the ability to do teaching and learning and interaction in much more interactive ways that allow for self-paced and self-directed learning, which is tremendous. That's not to say, though, that I haven't seen institutions throw up barriers to using electronic informed consent. So some of the biggest resistance that we got to the electronic informed consent process for the All of Us research program came not from the actual federal or state laws around research participation, but came from the institutions themselves, who said, but we've always done it this way. We've always used this templated language, which isn't so much a problem of e-consent, it's a problem of having forgotten the mission of informed consent broadly, right? Having boilerplate language that has to be in every informed consent form is not consistent with our mandate for the informed consent process. And so reminding institutional lawyers or others who are putting up barriers to using an electronic informed consent process, or really who are forcing your hand in any way with the informed consent process, about what the common rule is actually asking from us is an essential step sometimes in moving forward with something like e-consent.
I'll echo that. I think the biggest challenges we had similarly were trying to really enhance this culture shift in consent that has been more than 10 years of support to inform and protect potential participants rather than protect institutions. And the change change to electronic consent, and we're attempting to put things in really quite different formats and narrow down language so that it is very lay friendly. It's quite consistent with the common rule, of course, but it also is a huge culture shift. And so we found that working with our IRBs early and often was extremely important to help allow them to understand how we were still meeting all of the requirements for human subjects, that there is guidance, and I'll add there's FDA guidance as well. I mean, there are guidance documents that we can use as support for approaches, and those can be really helpful as well to helping IRBs understand the protections and the benefits potentially of this kind of engagement in the consent process. All right, anyone else want to unmute themselves and ask a question or put it in chat?
Well, I think I'd like to follow up on Aubrey's, what she posted in the chat briefly, with reasons for preferring an online engagement. And I guess what I would like to do is ask both Aubrey and the group what their experiences have been, and whether the issue of access, if you're trying to enroll a really, a broad group of subjects, the problem, if any problems with access online have actually come up.
I could certainly add something to that. We've used e-consent to enroll students, medical students, research master's students, and PhD students in a study in which we are providing them with interventions to reduce chronic stress and avoid burnout. And that goes pretty easily and is not really much of an issue. I'm not really sure how much they really know about the study when they enroll, but we give them a lot of information, and we get questions occasionally through email, which we answer. I don't think anybody really calls us. I assume the information is sufficient. It's not a very complicated study as far as that is concerned. The study design is pretty innovative, but I think for the students, it's not that complicated.
Thank you. Well, that actually gives rise to another thing that I think has to be thought about at least differently for e-consent than in some other studies, and that's the issue of privacy. Because you're describing a study that has interventions, and I suppose some people might think the subject matter is potentially sensitive. So one of the things that e-consent needs to do is to take account of the fact that people pick up other people's smartphones and things like that. So it's a little bit different landscape for privacy, but not any more difficult to protect privacy and confidentiality if you actually think through the issues that might come up and how they're different from paper consent. Take it away, Aubrey.
I'm happy to respond. I'm loving this session. Thank you, everyone. I would highly recommend a lot of the papers by Lisa Schwartz, who runs the National Center for Technology and Behavioral Health. We've been doing studies with her since 2007 online with e-consent, believe it or not. But that's because we were in a rural area, and so getting access to people was actually easier online. We did find, concordant with the Pew Internet group, that by and large, older adults and younger adults, obviously, were able to have cellular access even more than internet access. It was the middle group, that gap generation, people who are now my age, who have both a parent they're caring for as well as children that they're caring for, that we're having a hard time digitally and online. And that we don't know if that's a generational, if that'll pass as the next generation comes up or not. But I can report that across those studies, I have had very, very few people who were not able to participate. Like I put in the chat, we have up front learned very early on to explicitly state that we were providing funding for cellular minutes. In some studies that were looking at people reporting, we were looking at rural financial toxicity and drug use. So very sensitive topics, things you wouldn't think people would necessarily be wanting to report. We actually had much better, much more deep responses online, and much more volunteerism in our patient consent process. So much so that we had to back up and actually slow people down and say, now hang on, you need to understand what we're really talking about. They were more than happy to do that online because they were already online in these chat rooms and these groups. And that was the forum where they were already engaging. And they also weren't having to report something face-to-face to someone, which is a little more intimidating. So there was a lot of over-engagement that we also have to be mindful of. We did have, I think I put there the most recent studies that we started last year here. We're looking at cancer financial toxicity across the state of Texas. Many areas are very rural, many areas are very poor, no internet access in the center of the state. And so, yes, we did offer paper, we offered internet, we offered phone, and 99% of people wanted to participate online. The reason they wanted was actually to be able to do something on their phone. It wasn't on a computer. And so I think we need to make that distinction when we're talking to IRBs about e-consent, that it really does need to be able to be SMS enabled and multi-platform, multimodal. We always offer multimodal. I don't assume that it's only electronic consent. I'm happy to mail them the document and they can mail it back. We'll pay for the mailing, all of that. We'll slow it down. But 99% of the people, just looking at last year's numbers, we just submitted this for publication. 99% in 2019 wanted to participate online, and that was before the pandemic. I can only imagine how different it's going to be this year. Does that help answer that or add more depth to it?
Yeah.
That's really interesting. And we have another question, but I'll just add our experience with this. So the scale of our study does not allow us to mail copies of the consent. It's a very large scale research. We do it in for people who contact us, we do go through incredible means to help them sign up, but they have to take an active step and contact us, which is a limitation, and we keep working through that. Anecdotally, it tends to be individuals this is North Carolina, who are in rural areas and are Spanish speakers who contact us and say, we cannot do this. And so we've actually been really thinking through different approaches we can use with that population, including in-person recruiters who go and support them through their consenting process. But yeah, I agree. I think this is a real key thing to watch, because we also are seeing shifts, as you've indicated, and we do see there's sort of strata of individuals who are more comfortable and have more access. So it's an extremely interesting social study that we're doing on this kind of big scale. I think it's quite fascinating.
I do have a question for the panel,
sure.
if I can ask one really quick. Has anyone had, or perhaps I'm going to reword that, does anyone have advice for working with some of the registries? One of the things that I come up against often is that the registries will say, we don't provide email addresses. You have to call or mail this person some sort of information. And that actually presents a barrier to participation for a lot of people. Particularly now the younger generation, many of whom don't have a home phone and don't provide their address. And when they sign up to things intentionally, they only provide an email on purpose. Does anyone have any guidance or any experiences where they've been able to overcome that working with registries?
I can throw out some ideas there. Well, I'll start. So I do quite a bit of work with research registries that are owned by foundations and advocacy organizations and run into similar kinds of barriers. The best solution, and you've probably tried this, is that sometimes the organization will contact people in different ways. Rather than give you the information, they will do the contacting in different approaches that then they will allow you to do. And so we have been able to use especially social media to get around some of those challenges. So there are, closed Facebook groups, for example, that these groups have access to. And so that has been our best workaround. I don't know if other people have different recommendations.
That's a great idea.
We have a related question actually from Melanie, and so I'll just point that out, that there's a question about reaching your target population. So the back to the idea of partnering with community organizations to do recruitment. Recruitment is such a challenge and an interesting challenge. Or do any of the panelists or actually folks in the audience have thoughts about reaching target populations with these more innovative kinds of electronic approaches?
I just have to commiserate, even for the All of Us research program, which has, oodles of community partners and, really engaged lots and lots and lots of different groups. It's been difficult to continue with recruitment just because we're used to people stopping by community centers or, getting in more casual in-person contact where they might learn about the study. And so I think that what we're seeing is that people are really starting to adjust. We had like zero recruitment for several months, and then people started getting more facile with, having cocktails with their family members online or doing a FaceTime with family. And that then led to them connecting with their communities virtually. I think, unfortunately, as we in the United States face this next wave of COVID infections, we might find more people, again, learning to convene with community partners, or more people learning to convene with their community using online platforms. And once you get people onto an online platform, even if it's a community Zoom meeting, then you can get information out about your study. And certainly then having an electronic informed consent process is of a tremendous benefit. But it takes time for people to make the move to online platforms, especially in a lot of community settings, we found.
I'll
Yes.
add, oh, sorry.
Well, so you're still partnering with the community centers just through online social platforms?
Yes, absolutely. 100%. Yeah, they're still our partners, and those community organizations are still meeting in person. You know, one of the community partners that the All of Us Research Program has is Centerlink, which is the national organization of LGBTQ plus community centers, and they have really stepped up their online activities at all of the 280 individual community centers across the country that serve the LGBTQ plus population. And so, but it's taken a while for different stakeholders within each of those community centers to get online and to get accustomed to not just stopping by the center, but stopping by the center in a drop-in hour, for example.
Yeah, we've done a number of different activities, and it's as everyone knows, this is very expensive. And one of the things that we often don't build into our research studies is evaluation of the recruitment, which I think is vitally important that we at least attempt to do in grant funding so that we can evaluate which of these approaches work well. But we've taken a really wide-ranging approach to try to recruit, and it includes through community organizations and through other community resources. Like, for example, we have a partnership with WIC in our state, and WIC is providing information about our study to women who they serve. We have outreach, and we do regular engagement with the Native tribes in North Carolina. But we also are doing things like we have notices going out through MyChart at some of our major medical centers, and that's relatively novel, and we're tracking how well those kinds of recruitment approaches work. We do a lot of social media. We also send letters. We send a piece of paper in the mail. So there's quite a lot of different kinds of activities. And again, I think it's vital that we are doing assessments of the success of these kinds of approaches. We're reaching the end of our time already, which is amazing. Nancy, do you have thoughts about either the issues of recruitment or the idea of how we're kind of balancing the needs of fully recruiting these studies versus making sure that our participants are fully informed?
Oh, I think one of the challenges here is that everything is so specific to the particular study and the potential participants that you seek to recruit. The recruitment through patient portals, which can be through like your hospital chart or your primary care provider's office setup or whatever, is novel, and it's appropriate for a lot of different kinds of research, but not others. Like at my own institution, we're facing the challenge of setting up a committee to determine what recruitment is actually appropriate to do through the patient portal, simply because it's possible to do so many different kinds of recruitments that actually get pushed out, in addition to having people who have a MyChart or whatever account say, I'm interested in certain kinds of research. There's a big difference between saying I'm interested in this and suddenly receiving messages in your inbox, you qualify for such and such a study. So there's a complicated interface between the researchers and those who are in charge of the patient portal that's very appropriate. So all of this requires a different kind of thinking, as we've been saying all along. It requires a different kind of thinking from just figuring out how to deal with a paper consent. But the recruitment challenges and pros and cons sort of really remain the same, I think. And that has to do with how much time and effort one is able to put into recruitment, and which is just becoming a bigger and bigger challenge. And I guess we'll all see when we, as the COVID vaccine studies are going along, and who's volunteering for those, and how that's going to play out in terms of how people think about research, may actually have a big effect on what we're all talking about as well.
Great, thank you. All right, I think we are at the end of our time already, which is amazing. That went very fast.
So if people have leftover questions, I bet they can put them in the chat box, and folks will figure out how to get them to us.
I think that would be excellent. And please do contact, and I'll speak for all of us, please do contact any of us. We're,
Yes,
super excited about this idea of electronic engagement, both in the recruitment and the consenting side. So we'd love to create some more networks around people who have these like interests.
thank you, everybody.